without any further ado, we have our moderator, no other person than Sister Marilyn Reed Henry. And at this time, I am going to hand over to her as she introduces our guest speakers for the evening. Thank you so much, Sister Marilyn, and God bless you.
Thank you, Sister Hall. Good evening, everyone. And I'm Sister Marilyn, and we welcome you to tonight's session as we will be doing about seniors care. We did the aging process in 2 segments that we understand the different changes, physiological changes, and mental changes, emotional changes that occurs as we age. And based on that, there are different things that are needed to be done differently for our seniors. And I have to include myself because I am getting there. And there are things that needs to be done. And tonight we're going to hear get a lot of information from some experts in those areas. We're in an aging population, and even tonight, my daughter on her way here saw an elderly lady and decided to stop and help her. And in doing so, realized that this person was a missing person. And so the police was involved, and she had to wait until the police came and then hand over and stuff like that. So there's a lot of things that are happening to our seniors. So tonight, we just want to delve right into our session so that we have enough time for the presentation and the Q&A section that will come afterwards. Our first speaker, Laverne Smith. She has 35 years under her belt in the healthcare industry. She started working as a healthcare aide, returned to school, and completed her RPN. Years later, she went back and did her bachelor and master's in nursing. She taught the PSW course for a short period, and currently she works as a care coordinator with home and community care support services in Scarborough. She enjoys her role, and she's able to appreciate diversity and meeting with her patient. So she likes the hands-on interaction, not the office so much, but the interaction with her clients. So I just want to present to you tonight, Laverne Smith. Laverne, the floor is yours. God bless.
Good night, everyone.
Good night.
Can you hear me?
Yes, but if we could see your face, it would make it so
But
much.
yes, we can.
Okay. Okay. So, thank you for inviting me to this session. I do appreciate that that invitation, and I hope whatever I'm going to discuss with you tonight or present to you tonight, it might be helpful to somebody. And it's not a secret what is there for every elderly person, but it's just that a lot of times people don't know what is out there for them. So I'm going to be discussing about patients at home needing home care services or wanting to be placed in a long-term care facility. So home and community care support services, there are 14 divisions in Ontario that works within the communities to connect you with quality in-home and community-based services. We can provide you with information, direct access to home care coordinators, and many other comprehensive services. So services like with the agency that will provide the PSW to go in the home and assess patient or assist the patient. So a lot of patients are home, family members are taking care of them, family member get tired, do not want to be bothered, they have other things to do. Sometimes you can see the family members that they are so like look so drawn out, they are looking so tired because they spend a long time with their family members. Not that they don't want to do it, but they are doing it and it's becoming burdensome for them. So for that reason, there are agencies that are out there that provide PSWs to go home and take care of the patient. So basically, caregivers have to start trusting other people to come in their home. Sometimes you might be seeing different people coming in every day, but that's what it's like. So you have a scarcity of PSWs, you have a scarcity of nurses. It's just that there are so many people at home who need the service. So what do we do? Home and community care support service can provide acute rehabilitation, maintenance, and end of life home and community care service to you in your home. So even the patient who is palliative, they can get PSW services in their home. They can get nursing service in their home. And it's there through the government system. We can help you to come home from the hospital sooner, or we can provide you with information about long-term care options if it becomes difficult for you to live independently at home. So there are a lot of elderly who are living alone. They don't even have family. So if should in case a church member or any family friend know about anybody who would need that help, it's there that you can discuss it with that patient if the patient is able to absorb the information and get that person in. The patient can be referred by different ways. A family member can refer the patient, a church member can refer the patient, the doctor himself can refer the patient. And also patients that are in the hospital ready to leave, if they do not have anybody to assist them at home, they should talk out and let somebody know that they need that help so they can send somebody home and start the process. So also if a patient is dying, the patient wants to die in their home, you have that service too. So the patient can have PSW service, nursing service going in and assist. There are even patients who are at home that they don't have a proper bed. They need a hospital bed because at that time they'll need, like the caregiver cannot manage to do the care while they are on their regular beds. So a hospital bed would be preferably during that time. So that can be given to the patient on loan. And if after the patient deceased, then it can be returned to the industry that provide beds for the patients. So the role of the home and community care coordinator. So we have care coordinators that are nurses, OTs, PT, or social workers. And they are the ones who work very closely with the patient while they are in their home. So that's basically what I do. The patient will be referred to us. We go in, we see the patient within a specific time. We don't have any long waits, like maybe within 2 weeks after referral, we'll go in and see the patient. So in order for the patient to be able to get service, the patient has to be Ontario health card. The patient has to be over 18 years old, and the patient has to at least need service that they can provide. So the care coordinator or whoever it is, the nurse or the OT, whoever that person is who is going to be the care coordinator, they will go in to see the patient. They'll ask the patient with family, if there is family, or whoever is volunteering or helping that patient. They'll meet with them. Most of the times, the doctors will do the referral too, like if the patient is coming from the hospital. So with that, they'll go in the home and they'll assess the patient, ask them some questions, and by doing that, they will come up with a score with the amount of hours that patient can get. They don't, the PSWs do not work as babysitters. They work they go in to see the patient, help the patient with light housekeeping, light meal prep. They will assist with their care, giving them a bath. If the patient want to have a bath, they can have a bath. If the patient want to just have a shower, they can have a shower, whatever it is. And it all depends on how long that PSW is allowed in the house. So basically, this service is given to them, but depending on their care needs. Like you have some people who are home, they can do something for themselves still, but they just need that bath. They just need somebody to be there to assist them in the bath or assist them to let them have a bath safely. So that's always one of the reasons why they get in. So as I mentioned before, you have to have a valid HOHIP card. The patient needs that cannot be met in the outpatient setting. So take for instance, if a patient needs a physiotherapy, some physiotherapy goes to the home. The patient doesn't have to go to a physiotherapy in the community. They can get that service at home. A OT also can go in and assist patient too. So also a medical condition that cannot be adequately treated in the home. So as I mentioned before, palliative. If they're palliative, they can't be going out to the doctor every day or going to a clinic to get care. Some patients might need IV infusion, or they might have been getting chemotherapy, and they need their chemotherapy to be disconnected, or they need IV hydration. Nurses can go in the home and do that service for the patient. So if a caregiver realizes that their loved one needs some help, the caregiver is able to call in and refer the patient. Within the whole region of Ontario, there are different, as I mentioned before, 14 LHINs. So out in each area, like in Scarborough, where I work, we have our office. In Toronto Central, there are offices. In Central, there's office. In Mississauga, we have office. In Brampton, we have offices. So it's just for people to find out exactly where they are. I don't have their numbers, but it is out there where you can always search for it. It's all on Google. Even children can be referred to home and community care, because there are a lot of children who are going to school who have behavioral issue. They're autistic. They need that service. Some of them might be needing insulin injections. They might have different things that has to be done for them. They get G-tube feed, and they might be going out into the community. Home and community care support services have services for these patients. So the other thing is, then it comes to, if the patient cannot manage anymore at home independently, then the patient might be referred to a long-term care facility. They have their long-term care facilities, and there are retirement homes. So the options are there. So for retirement home, patients are private, these retirement homes are privately owned and operated. So it's not like the nursing home. However, they are suitable for seniors who are independent but may still need assistance. They provide meals, housekeeping, and laundry. They may also assist with bathing, dressing, and administering medication. And applying, you have to apply directly to the retirement home for that admission. And accommodation costs are not regulated and do varies. So some retirement home might be upper scale. They have so much amenities and they want to sell themselves, so they're going to be charging even more. So whatever they want to charge, and at the same time, the home and community care support services provide PSW services for the retirement home patients too, because not all of the services is given to them through the retirement home. However, for Ontario, if you notice that the government is trying to make sure that long-term care facilities are available. So they're building more, or they're expanding more on the nursing homes now in Ontario. So patients that are in the retirement home, patients that are in the supportive housing setting that can no longer manage caring for themselves, it may be time for them to consider a long-term care home. And that's also for the caregivers. Consider getting your loved ones into a nursing home if you cannot manage anymore. Like most people, especially our ethnic group, we do not really like such setting. And but if you cannot manage, you can still visit your family at the long-term care home. They are wide open for you to go there anytime. They are always open for that help. So a care coordinator can assist patient and family through the process of applying for admission to any long-term care home in Ontario. I'm not sure if you guys all hear about Bill 7 recently. So there are a lot of patients who are in the hospital. They were there for months, especially during COVID. A lot of them were there. They can't go home because they couldn't manage anymore, and the way how they reacted to that COVID. And what really happened now? They decide that patients, if they cannot go home, they still cannot wait in the hospital, so they have to transfer them to another area, something looking like a nursing home. So we have quite a few of them right now in Ontario that patients can go and stay while they wait for long-term care. But if you notice, there is a cost to it if you do not get your family out or get them somewhere where they can at least stay for the rest of their life. So what really happened, if that cost might be too much for a family. So it's always important that if you try to get help from your other family member, take your family member home, you may be better off, or getting them into a long-term care is the other option. So there are services that are available within the long-term care home are nursing and personal care. So you can get a nurse while you're in a long-term care, nursing care. So that's when the nurse will manage the patient's medication. Should in case the patient have a dressing or wound to be done, the nurse will take care of that while the patient is in the long-term care. PSW services are also available, and that means the PSW will assist with activities of daily living. There are also meals that are provided. Patient can choose the meal that they want, because usually they'll present them with maybe a list of different menus, so patient can also get that. Patient can even get meals delivered if they want that to happen as well. Laundry services is done there, and recreation is also there at the long-term care. So patients, I know that a lot of patients, because of their age, they might not be able to get involved in some activities, but at least there might be something there to entertain them. So they do that. However, there are eligibility criteria for patients in the long-term care. So home and community care must assess and determine the patient's eligibility for long-term care. And in order for one to be eligible, as I mentioned before, they must be 18 years of age or older, have a valid health care card, that's their HOID card, and the care that they need must not be available in the community. It is only available in the nursing home. Also, to be eligible for admission to the long-term care home in Ontario, it must be determined that all the publicly funded community-based services, including retirement, supportive housing, convalescent care, or other caregiving supports or companionship arrangement available to you are not sufficient to meet your needs. While in each long-term care home has the right to approve your application based on their ability to meet your needs. So, like, I will go out into the home and I'll assess the patient, and then our assessment will say, yes, the patient is eligible for long-term care. However, certain long-term care homes have different criteria that they follow to be able to admit that patient into the home. So a lot of patients have behavior issue that the long-term care might not tolerate. So if they cannot tolerate it, they are going to turn down that application, because some patients might wander. They have behavior where they wander. They have to be in a locked unit. They might be the one who might be hitting on other patients. So you have a locked unit. So if they do not have a locked unit, they cannot accept that patient. So in that situation, if they are not able to accept the patient, they will always send you a letter in writing informing you that they cannot admit that patient. So there are convalescent care homes as well. And for these convalescent care homes, there are patients who might have had surgeries or serious illness. They may not require hospital stay, so they can leave the hospital, but then they cannot go home because it's not safe for them to go at home. So convalescent care is always available, and sometimes the doctor will be the one who would refer the patient to the convalescent care. The same eligibility criteria as admission to long-term care home applies for the convalescent care. And convalescent care is not intention to serve individuals needing complex continuing care or palliative care. So convalescent care is usually provided for over a period of time, like 30 to 45 days. A care coordinator from the central, from the LHIN, from home care, will help with that program as well. There are also short stays that are available in some of these nursing homes. Like if a family member want to go away on vacation for a period of time, they can get their loved ones into a short stay respite program. And also that one, the care coordinator will assist the patient in getting that application done. So the short stay respite is designated to support family caregivers by providing relief for their caregiving responsibilities. As I say, if you want to go on a holiday, if you want to go out, you cannot afford to pay a sitter because most of the time the sitters, they cost a lot of money. So the cost for a night is how they will charge you at a respite. So I don't think a respite care even costs up to $50 a night so far. So that is also available. The maximum length of time for respite is about 60 days at a time. So the patient themselves, though, at if they're getting home care service during that time, the patient cannot get more than say 90 days of respite for the year. So that's also a service that is available for the patient. I am not sure if I was able to deliver everything that you guys need or the questions that you have in mind, but I'm open for questions and we can start.
Hi, Laverne. Thanks for coming on. I have a question. You used a word, and I'm not sure if everyone knows what this word means, so I'm trying to get out of the light. And it's palliative. You said if someone's at home, community care access can also provide palliative care. Can you delve into what palliative care is and what it entails? Thank you.
Okay. So palliative care will be for a patient who is dying. So if the patient is dying and they are not in the hospital or they are not in a nursing home and they do not want to go to a hospice, they want to die in their home, palliative care is provided there as well. So you will have PSWs who are specializing in palliative care. You have nurses that are specializing in palliative care. So that agency, home and community care, will direct you to that agency, get the agency involved, and get the palliative process started. And there are also nurse navigators in the community that are available to go in and see those patients, and also doctors go visit those patients at home. The doctor will determine like the prognosis, and then they will have, like if they want a DNR status, they cannot get a DNR status. If they want the patient to be treated, however, like most of the time it's because they don't want anything else. They just want the patient to just die comfortable. So whatever treatment they want, they can get it at home. They can get pain pumps set up. They can get like narcotics in the home for the patient, and the nurses will go in and administer their medication via IV or any different injection or whatever. So does that answer your question, Karen?
I think that's a very good answer. She's probably stepped away. And thank you so very much for your presentation. It was very, very thorough. I learned from it. And I'm in the same industry. I've learned from it. My question is, you said that they need to have an active health card. Say, for example, there's an elderly person and things have been lost or the health card has expired. Does someone help them in getting a new health card?
No, that's the responsibility of the family to make sure that the patient have a health card. But ever so often, whenever the care coordinator have an encounter with the patient, the care coordinator will always make sure that the HOHIP card is valid. And as long as the patient is in the system, they will be notified. We will be notified that the patient's card is expired, or and most of the time it's because the version code changes. So and again, sorry, for the patient to really be admitted, they do need that card. So family then has to make sure that the patient get the card up to date.
Okay, thank you. And everyone, if you have questions, you can post it in the chat, or you can put your hand up, or you can just speak up. We just have a few more minutes with Laverne, so let's make good use of it.
This is Eugenie here. Laverne, I think there are 2 questions in the chat, please.
Okay.
I did ask the first one. The second one was also posted by me. What's the average cost for long-term care?
Okay. Recently, things have changed. There are at least 3 different price range, because you have patients who want to be in a private room. You have patients who want to be in a semi-private room. You have patients who want to be in a basic room. Recently, they changed semi-private and basic to be the same kind of, like 2 patients sharing a room. They do not have wards anymore, most of these homes, especially the new ones. And that cost is almost $2,000. And for the private, it's high 2,800.
That comes from their pocket, or?
So if most of the times, yes, if you want a private room or semi-private room, it comes from the pocket. But patients who have their pension, that's considered, and the government match the rest of the costs. But that's for basic bed. If the patient wants to be alone in their room, then that's the family's responsibility to top it up, to pay more. So most of the times when you see people wait for so long before they can get into the nursing home, it's because basic beds are to come. And private beds are available, and most people cannot afford the private.
So my question to you there now, I think you said for private rooms, 2,800, I think. Is that per month?
Monthly. Give me 1 second, just let me tell you the exact amount current. Yeah, that's monthly.
In other words, they have to sell their home in order to be able to pay for long-term care.
Yeah. So basic, kind of even was very low. Like since July 2023, the basic for is 1,986. Semi-private, 2,395. And private, 2,835. Short stay, $42.28 per day. And it's the same right throughout.
Okay.
So this is even more than what lot of people pay for their rent, right? But I think it incorporates the care, because if you have to pay somebody private, the cost is gonna go up there. But as most of the time, and as I say, for our culture, we try to keep our loved ones at home, right?
That's what I was gonna ask, like, how do you help family in the decision-making process, considering there's the cultural belief that makes one not want to place their loved one because it gives a sense like you're giving up and the guilt and all that. And it's not just with the West Indian culture. I find it with other cultures because I've worked with the First Nations, and it's one of the hardest thing when it comes to placing them, because most of for the they end up going outside of the community. So the visiting and all that, it doesn't happen. How do, yeah. So how do you help them in that decision making and transition?
So at one point, the family members were the one who were making the decision that, oh, my mom cannot stay home anymore. I cannot manage. I have my family to take care of, and I cannot do it. So that's where we come in, where we get the PSWs to go in and support. But at that time, we realized that there were many people who were going in the long-term care home that did not want to go. And for that reason, they came up with this thing where they have to do a capacity assessment on the patient. So remember, a lot of patients it's all because they have dementia, or it's not, dementia is the main reason why a lot of patients are in there. And they cannot understand what is going on, but they definitely can make a decision to say, I don't want to go, or I want to stay home. So family was getting them into long-term care, and they did not agree. So by doing a capacity, every patient, before they can go into a nursing home, we have to do a capacity on them. And if by the questions that they respond to, if they can do that successfully, then the patient make the decision. I won't go there, and that we cannot force the patient to go. So we are not even a part of that. This between the patient and their family. When we do the assessment, if we realize that they are capable of making their decision, we have to discuss it with the family. Say no, we cannot do that. But if we find that the person is incapable, then that's where the family steps in, and the family get the right to get them into a nursing home.
Awesome, thank you. I would like for you to stay on with us. I'm gonna get Philomena to come on and do her part, and then we'll continue with Q&A at the end. Is it possible for you to stay on for a bit?
Sure.
Thank you very much for attending and for this invaluable information that we have received. I do hope that Philomena is on. She's supposed to be joining via telephone because she's en route. So I'm going to present her and hopefully she's here. So Philomena Matthews has a master's degree and 25 years as a social worker. She's working with seniors and also work at homeless shelter and abused women's shelter. So she's going to be coming on right now to do her part as we continue to talk about seniors here. Welcome, Philomena. God bless. I'll give her a few moments because sometimes it's hard. Okay. It appears that she has not joined us as yet. So we're going to continue to our Q&A and see when she's able to join us. Any other questions anyone have?
Yes, I have another question for Laverne. Now, we're talking about, for example, the private room at 2,800. Does that include medication, Laverne?
Yes.
Okay, it does include medication. And then you were mentioning like a few services, and I was wondering if all those services are covered by OIP.
So are you talking about the PSW, the nurses?
Yes.
Yeah, so the nursing home provides 24-hour care. So after with all of that cost that the patient pays for their stay, the nurses are it covers the nurses, PSWs, OT, and PT service. Yeah.
What is OT and PT, please?
Oh, occupational therapies and physiotherapy.
Okay, thank you.
Sorry. So even as I mentioned before, even in the homes, patient can get those services, OT service, nursing service, and that's not a cost.
Awesome. Thank you, thank you. I get to understand that Philomena is on. So go ahead, Philomena, welcome, welcome, welcome. If you're calling in on your phone, you need to press *6 to unmute. Great. We're going to continue with questions until she's able. As soon as you are able to, Philomena, you can just interrupt us. We're just gonna go on with some questions while you feed the glitches that you're encountering. Anyone that's considering or having that challenge of should I or shouldn't I, not coping, this is getting too hard, you know, those kind of things, like, and you have questions to ask, go right ahead. You can post your questions, you can text your questions to me, I'll read them for you, because I know I can feel the questions there. Is that Philomena? All right, I'll ask a question. When it comes to resuscitation, we use the term DNR. Do not resuscitate.
Hello?
Hi.
Hello, can you hear me?
Yes, is that Philomena?
Yes, yes.
Okay, go ahead.
Okay. So I can talk what's from the long-term care perspective. So when we get the application from the home and community care, like, thank you, Lavan, that was a beautiful presentation. So when we get the application, we go through the application to see whether we can or not. Of course, we have to admit everybody, but there are certain criteria we cannot take in. Like for example, if somebody has a trach tube or anything like that, we will not be able to take care of that person in the long-term care. So once we accept a person, again, in our long-term care, we have behavioral unit too. So people, for residents who have behaviors, we put them in the butterfly unit, which is a specialized unit for behaviors due to dementia. And the social worker connects with the family and lets them know what they need to bring to the long-term care. Of course, Lavan explained about the money part, how much they need to pay for a private and basic. So they have to provide us a void check, power of attorney papers, because that's very important. So the nurses or the doctor has to, when they need to call, they will only talk to the power of attorney, that is the substitute decision maker, if the person is not capable. If the person is capable, then they will talk only to the resident. If the resident is incapable, then there is somebody else who takes part, whom the nurse will be contacting to inform all the health status. So that is very important for us. The next thing is we tell what are the services we provide. So we have, of course, we have 3 meals per day, in between 2 snacks. There are some like for diabetic or dialysis. So everything is catered to the resident's requirement. Also, 2 choices are provided, so the staff can show these are 2 choices, the menu, and they can select which menu which is wanted. Saying that there's residents who are non-verbal, so you can ask me how does a non-verbal resident get the menu of his choice? Again, when we get the application, we get all the diet information. So based on the diet information, the diet is provided to the resident. Our dietitian also calls the family, and this is the diet, and the family can give in their input. So that is catered to the residents. The next thing is we have activities. We have a lot of activities catering to the residents' needs. Mostly, I can tell you 95% of our residents have dementia of some sort or the other. It can be moderate, it can be severe, or it can be just starting stages with other health concerns. So activities are catered to them. They have outings also. They take the residents outing for shopping, for East Side Mario, for lunch. What is the next one? I don't know, outside lunch. They also cater to that. Then we have hairdressers. Hairdresser who comes twice or thrice to do, for hairdressing. And also we have the foot care nurse who comes in to do. We have the dentist who comes for the dental work. And we have even, I think so, even the eye specialist, not the specialist, but they come and check and see if they need glasses, or any further, it's a referral outside. The family brings the resident. They can't bring in a whole lot of things, because we at the nursing home, anywhere, they provide the hospital bed, which is a standard bed provided by the ministry as the standards, and accordingly we have to follow. So there is a bed, we have a chair, we have 2 side tables and a closet. So in case if the family wants to bring anything, it has to go through the physio to see if it is safe for the resident, because most of the residents are at false risk. Okay, so what happens is can you hear me? Hello?
Yes, we can. There are occasions when you're chipping out, but for the most part, we're hearing you. We're getting you.
Oh, okay. So if the family has to bring in any of the furniture, it has to be okayed by the physio, because most of the residents have falls, right? So if they hit and fall, it's for the resident. And when they fall, they can hurt their ankle, they can have a fracture. So the physio will assess and see, okay, if this is required, if they can bring in a lazy chair or not. That's how it is. And when the clothes are brought in, the clothes are labeled, and so the room number and the name is put into the clothes. So, you know, when it goes for laundry, it comes back to the same resident. I think we have doctors who comes once a week. We have nurses, 24 hours nursing service. We have 24 hours PSW service. In addition, we have the BSO nurse. BSO nurse is a behavior support nurse, behavior support Ontario nurses. So we have one in our, not only in my long-term care, but in all long-term care, we have the behavior support nurse. Then we have the nurse practitioner who is in-house all 5 days a week. Her role is to see to prevent unnecessary transfer to the hospital. And she can assess and she can even prescribe certain medications. So that service also we have. And then we have the geriatric doctor who the BSO refers and sees in case if some behavior becomes a little more than we could manage. Sometimes, you know, due to dementia, not only wandering, they can also, you know, have making noise or going to each other's room or something like that. So that will be again by the geriatric doctor whom we have. Pretty much I have covered. Unless you have any questions, then I can answer, please. Hello?
All right. Hey, are you
Hello?
still there? Are you still there, Philomena?
Yes, I am here.
Philomena she's open for questioning now, Sister Marilyn.
Okay, I didn't hear that. All right. Thank you, Philomena. Anyone has questions for her?
I have a question, Philomena. It's Karen. So I moved into the long-term care, but I don't like it. I thought it was great when I looked and the room was lovely, but then I realized the services aren't what I expected. It kind of fell below my expectation. What do I do? Because I cannot bring my loved one back home because I already did not have the means to care for them. What do I do now?
So that's a very good question, Karen. So you mean to say the resident doesn't like the home or the family doesn't like the home? Karen? Can you hear me?
Can you say it again? There's some.
Yes, actually, sorry, yes, I was trying to unmute. Neither of us like it. We both thought it was going to be fantastic. You know, when I did the tour and when I looked online, it really looked like, you know, the senior dream. But now I moved my parents in and we both don't like it. Where do we go when we don't like the home that we're in?
Okay, here is a question. I think Laverne can support me in this. So if my first question is, does the family like the home or didn't like the home or the resident didn't like the home?
So, we usually have the patient choosing at least 5 homes when they're making their application. So, and we do ask the family to visit the home first, make an appointment with the home. They do tours, so you can get to see where the home that you're choosing. A lot of people do that, and if they choose that home, and when they have a 24-hour to accept the home. So if you want to go, if you never see the home and you want to go see the home, you should do it within that 24-hour period. If that's your first choice that you had, because when you do the application, you put your homes in ranks, 1, 2, 3, 4, 5. which one is my favorite. The best, my favorite would be my number one, and so on. If you choose your number one, and when you get your number one, you decide that you do not want that home, you lose your spot, and you will not be able to keep an application open until 3 months. So you have to reapply. So we always encourage family members to do a tour, go with the patient if the patient is capable, and see what they have to offer. See if this is where you want to be forever. And then it would be a better thing to do instead of when you get it, you say you don't want it, you don't like it. Does
Okay.
that answer my
The
question?
question which Karen is asking is different. She's asking what after coming to the home, what will happen if the person does not like the home? Is it what Karen is asking? Karen? Karen?
Yes, sorry, I'm hearing, I was muted. Yes, that's what I wanted to know. So if we go in and we don't like it, yeah, not during the process of the application, but we move in. I move my parent in, but they don't like it. I don't like it. What do I do? Do I get to still use my number? Say this was my number 5 home, for example, but my number 1 home isn't ready. I don't even know. Do I get to pick a home again? Or do I just have to live with it until my loved one passes away? What are my options?
So that means if you're gonna be going to that home, Karen, and if it was the number one home that you choose, you would have to reapply because you do not have an open application anymore. If you did get number 3 home and you know you want to get your loved one into the home right away, if you had received the number 3 home, then you're still open for your number 1 home. So yes, you will still have an application waiting and you will get that home when it becomes available.
To my understanding, what Karen is asking is, once the resident comes to the home and if he or she doesn't like the home or the family doesn't like the home, what is the next possibility? Is that what you're asking, Karen?
Yes, that's what I'm saying. What do I do? I know I have the option, for
Yes.
example, if it was my number 3, but
Yeah.
what do I do in the meantime? Where do I put my loved one? Because I can't bring them at home. So
Yeah.
do I get stuck in the home until another choice becomes available?
Yeah. So we had a couple of residents who came. The family could not adjust. The resident could not adjust. He wanted to go back home. So we had to inform the LHIN, the Home and Community Care Service, that this resident wants to go home. So the community care, the CCSC contacted the family. So what happened is they put in the services back. So whatever PSW services they are at the back. So the support services was set up for them at home, and this resident went back home. Now after that, what happens, I don't know, because their file will be closed, and if they have to reapply, it will be again at the bottom of the list. So that's their choice. If they don't like, the family has to make all the arrangements to go. Because the family knows what it is. They have toured the place. They know exactly what is it. But sometimes the resident who is cognitively there does not want to stay, even though the health status requires a lot of help still. So the family makes extra arrangements, and maybe they must be having private caregivers coming and helping them. That's how it works, Karen. But eventually they all come back. Eventually they all come back as crisis, because we had somebody who left, and now I was reading the application, they want to come back again. So it's going to take time where there is no bed. They realize when they go back to the community, they think, oh, they can manage, but as your health deteriorates, there's no other help. This is all these helpers, only certain amount can only be helped outside. But in the long-term care, it's not like that. There is 24-hour service given. So they have to reapply and it becomes crisis. And again, they will not get the same place. Crisis means wherever it is available. So we have now an application waiting to come, but we have no bed.
Good night. I have a question. Is it possible that the patient or the relative could look at the homes before they make their choice?
That's
Yes,
what
or
he
they have
suggested.
to?
Yeah.
That's what Lavan also said. They're given time to go and have a look.
Before they make their choice. Okay.
Thank you. I'll read a question here, and I think we kind of covered it, but there's more details here. Family members diagnosed with dementia and safety is becoming a concern. Family members are torn about loved ones living in an assisted living facility because it is a loved one wish not to live in a nursing home. Our culture has a negative connotation about sending our loved ones to live in a nursing home. And not sure if you covered that already, that's what you said. How can you encourage someone who's struggling with these decisions?
That's a very good question. So we have all the support systems. We have brochures. We have the Alzheimer's Society. You can join them, the society, and you have the community resources which helps you to understand what is dementia, how many types of dementia is there, caregiver stress. All the resources are available in the community. Please join that and get all the help you need. Supposing the family wants more support, the social worker is there to provide the support, the nurse is there to provide the support, the DSO. It takes time for the family to understand, usually at least 15 days for them to understand, okay, this is the reality, this is how things are working here. So any concerns they have, the nurse attends to that, everybody attends to that. But I always tell my family, give time. Give time for the staff to understand the residents and the family also to understand what exactly it is going. You can't get things done in a switch. Everything takes time to understand, especially when you're putting your loved ones there, right? And the biggest thing what I find among the families is the denial. They are in denial. Oh, my mom is okay, my dad is okay. Even though they know the complete health status of their loved one, but the denial plays a very important role. And to take out the denial, it takes a lot of time. But usually when time is given, they accept it, and it's very good. It's very good. The end product is very good because there's a lot of support system available. They meet the other families. They talk about that. We have family council. We have resident council. So they meet other families. They get to know, okay, this is how you're dealing with this situation. This is how I deal. So there's a lot of support available.
Thank you, Philomena. I think that it's a topic that should be discussed even way before you need to make that decision. And
absolutely.
I know for myself, every time I bring up those topics to my children, they kind of, dismiss it. But gradually they are having a bit of better understanding because it's like, okay, if I reach to this part and I talk about do not resuscitate, I don't want my chest being, my ribs being broken and all those things, and not having a full life just for me to be alive, for someone to look at me to say that I'm alive when I'm not really at my best and I don't know what's going on. So it's things that we need to discuss as families. When there's lots of siblings, you get the family together, you talk to them. When mom or dad needs more care, how are we going to do it? do we rotate, 1 week at your home, 1 week at the other home, so that none of us get burnt out? And when it's reached a point where we can't handle anymore, and safety, because so many times we hear of people going missing, as I told you what with my daughter, finding someone that's been missing and had to wait until the police came to take her. But most times the result is not a good one when they're found. So if we really care about our loved ones and we want them to live as long as they possibly can, when dementia reach a point where there's safety issue, we don't want them to be at home. They'll open the door, they'll go outside in the heart of winter and not properly dressed. And you know what that means. So we really have to be realistic in our thinking and our decision and our conversation, and not let guilt and culture and what other people will say, because look, your mother look after you, when you couldn't look after yourself and it's your turn and you're giving up on your mother or your father. Like, that's not the reality. So we just have to be real and talk about it as people are living longer and dementia is starting even sometime at an earlier age.
Yes, and you're right. Also, I forgot to tell something. Once the the patient is admitted, we have a family care conference where the doctor, the nurse in charge, the physio, the activation, and sometimes the social workers, all of us join us in a meeting and then discuss the complete health status of the resident. Sometimes the resident is also taking part. And it's a beautiful meeting where everybody discusses and the doctor says this, discussing complete health status. So that is very important for the family when the multidisciplinary team meets to discuss about the resident. So that also takes place in the long-term care. So that is also a very plus point. And also, if the families have any questions, they always call the nurses and ask, how is my mom doing, or how is my father doing? Did they eat today? Did they take the medication? Or in case if the medication is, sometimes the resident refuses, the nurses call the family and say, she is not taking the medication. Can you help? So sometimes the family calls and tells the resident to take the medication. So all the support systems are available in the long-term care. I'm not talking of our home, but generally, this is how they function. So that's why I always say give the resident time and the family more time.
Thank you, Philomena. And I encountered that because I had to place my mom, was in the long-term care for 5 years. And I always attended multidisciplinary meetings, sometime by myself, sometime with one of my other sister. I think she's on right now. That we'll go to the meetings, and I think it used to be annual. Yeah, I think it was annual, and they would even do the care, what you call it, where they would decide whether we want to still have her as a PNR, those things would take place, and if we have any questions. And I was really impressed with the care that was given at that facility. I can say that. And whenever I go to visit, I do all of the care until I leave. I go in, I'm giving her a bath, I'm feeding her, I do all of that. I said, Lord, I've been doing that for my mom, so when I'm here, I will do it.
And that's a comfort for you too, right? You feel so much comfort in doing for your loved one. We have some families who do that. They find so much comfort and happiness in doing that.
Yes, definitely. And because being on both ends, I don't want to be that person to say it's your job, so you should do it. I'm just here, standoffish and all that. No, we are a team together, and it's my mother that I care for. And yes, it's your
Yes,
patient
yes,
that you're getting
yes.
paid to do the job, but I am here and that's the least I can do. There's some questions here. If my loved one is hospitalized and need to go to long-term care from the hospital, is there anything in place for the patient to be part of the tour? So the family is not making the decision for the patient.
I can respond to that question. Well, if the patient is able to go on the tour, that would be good because at least the patient is seeing what they're looking for, right? So if the
Yeah,
patient
yeah, they
is
can
able
go for
to-
a tour. Yes. Sometimes the patient, the residents come for the tour to have a look, or the families take picture of the room and what is available also. Okay. They take pictures. We give them a tour guide of the home, which with all information is there. Okay, I need to leave the meeting now. I have something important, something else to do. So I thank you all. I thank you all for giving me the opportunity. Okay.
Thank you, Philomena.
Hello.
Thank you for making yourself available. Well appreciated.
You are very welcome. I thank Karen for asking me. I have to leave. I have to make another call. Okay. Thank you so much.
Okay, keep being busy in what you do. Thanks.
Okay. Bye.
Another question is, it's very difficult when some family members are not able to have a discussion about care for aging parents. The speaker is correct. Denial is a great part of it. So we're just acknowledging what was stated.
Sister Marilyn, if I may interrupt you, Laverne was not through answering the question about if the patient should be leaving from the hospital to the long-term care home. So Laverne, if you don't mind, please.
I think Philomena responded to the question too. So that's basically what I was saying. Usually it's better for the patient to go see the home as well, if they're able to, because being in the hospital and they have to go into the nursing home. Are you saying that the patient is going to be going straight to the hospital straight to the nursing home from the hospital? I'm not sure if that's what they are asked.
Yes.
Yeah. So it would be good if the patient is able to go. But usually it doesn't really happen like that unless the patient is going to be there for a while waiting for the bed. You know, sometimes it's not safe for them to go home, so they might be staying in the hospital and waiting. So again, you have to look at that if the patient is going to be able to go even for that tour.
Yes, yes, that's true, because if they're not well enough to go home, it's gonna be a hard thing for them to go to the facility. Say, for example, if it's a stroke patient and they have weakness as being resolved, and the family member is not able to care for that time.
Right. Yeah.
Going from the hospital to that facility, and with the mobility and all that, it might not be possible. So maybe like these days you have so much video, you know, they could go there, they could do FaceTime and show what's happening.
Yeah, usually they can do a virtual tour.
Yeah.
I'm gonna go as well because I have to go to work. So thank you for allowing me to speak. And anytime in the future, you can always call on me if you need me.
So thank you very much, Laverne, and thanks, Sister Karen, for getting these two wonderful guests with this information, current information that is so invaluable, and I appreciate it, and And Sister Hall, our First Lady, and leader of the group tonight. Say your words to Sister Laverne.
And can I say that Laverne is my old batchmate? So she's my old friend of over 30 plus years. She was a batchmate of mine. And then we've reconnected recently.
Awesome.
Now, I just want to make a plug for the nursing home, and not because I belong when I don't belong, not because I work in that sector, but for those who bring their loved ones in, we just want to let you know that they're not moving to prison, which means you can visit whenever you want. You can bring in your choice of cultural meals, provided it falls within the scope of what they can eat. We don't expect you to start bringing them some yam and bananas and chicken feet when you know that they're on a modified diet, like a minced diet or a puree diet. Don't do that. You're going to hurt your loved ones, but they can still enjoy those meals. They can go on vacation. So providing you're able to get the means for them to go on holidays, they are still entitled to vacation time. I think it's about 6 weeks per year in its entirety. So you can bring them home for that special event like Christmas time or Easter time. They are not in prison. In the long-term care, they have rights, and those rights must be adhered to. It must be respected. The rooms are personalized. It comes with a very basic, which is the bed, the night table, the Chester drawer, but you can bring in that favorite couch. You can switch out the Chester drawer. Maybe dad made that Chester drawer. And so it's very sentimental. You can bring those things in. They can have their TV, their telephone. It is not the end of their life. And let's not have our culture manipulate what's right for them. Do not keep that loved one home that's just going to lay in the bed all day long and you're talking over their heads all day long. Meanwhile, they can be in a place where they're with their peers and they're having programming that's matching cognitively where they're sitting. Don't take those things away from them. Not because our parents or our loved ones are in a wheelchair means that they're locked away. They still go on these outings. They go to Blue Jays games. They go to everything that's happening out there. They're still very much a vibrant part of the community, depending on where they sit cognitively, because everyone doesn't come to nursing home because they have some level of memory impairment. Sometimes medically, it is just too much for a family member. Sometimes they just don't have that family support. They may never have had children, or their children are deceased. So that kind of leaves them alone, right? And as parents, we don't want to overburden our kids and, for lack of a better word, kill them with guilt. I don't want to go to poorhouse. Do not put those guilt trips on your children. And I'm saying that for myself too, even though I have told them, just come one day a week and bring me a little chocolate and a little piece of Ardo bread and two little slice of plantain. I don't ask for much, right? But let's not overburden our kids with guilt. I am not going there. And then they get to the point where they physically cannot do it, or mentally they cannot do it. And then they feel bad. Oh my God. And then I said, can you imagine? She has 10 children and in a nursing home? Please, as a set of people that love the Lord and desire to follow the Lord, do not use your words to manipulate people into the trip of guilt. Please get off the guilt trip training. Don't do it. Let us make wise decisions. For those of us that are aging, do not wait for your children to make decisions for you. Get out there, pick up the phone, call those nursing homes, call the social worker, whomever it is that manages a tour, and say, I would like to have a look at the place. You may not be ready for it for 15 years down the road, but be a part of the decision-making process. The last thing I'm going to say is, study shows it takes an average of 6 weeks for one to accept long-term care placement if you were involved in the process. Thus, that's why that meeting occurs at that 6-week margin to see how things are going. So don't let other people make decisions for you that you weren't quite on board with. Get out there, go out there, see these places, have these conversations. Thank you so much for joining us. Thanks, Sister Marilyn.
Thank you, Sister Karen, and thank you, Laverne. Lady Hall, do you have any final words?
Can I say something here, please?
Yes, go ahead.
This has to do with what Karen has just said. That was very, very important piece of information given there. And I hope we all take that into consideration, knowing that every word she just said, we are to look at it because that is happening here, there, and everywhere. Very good input, Karen. Thank you for that. Thank you.
Again, thank you, Laverne, for joining.
I would like to say something as well.
Go ahead. Who's,
I can relate to everything that both speaker was saying a while ago. I had a friend who has no family here in Canada, and I realized what was happening, that dementia was setting in. I pretty much was left with every single thing. I was, like from start to finish, doing the assessment, going through the whole process with Lynn, and every single thing. I had to go through that. And because there was no spouse, no children. So I had to go through all of that. I had no idea what I was in for. But even to today, I mean, there is one of the sisters is now the decision maker, but everything flowed through me to her. And last 2 weeks, I was just on the phone with all the doctors, the nurse, everybody, and they're talking now about, okay, when we walk in the room, if he's dead, what should we do? What kind of funeral arrangements? I'm thinking, like, how did I get into this? But, as a Christian, some of the times, you can't turn your eye away when there's a need. So I'm telling you, I know everything about this whole process. So that's all I want to say. Sometimes you just, even though it's not your own family member, but sometimes it could be a friend that you have to step in and help out. And I just thank God for giving me the strength to go through all of that.
Thank
Because
you.
even to today, if they can't reach the decision maker, the other day, the meeting with all the doctors and the nurses and the PSW and all these people, like, it was just me there, like answering and asking questions, and then I have to relate it back. So just thank you for this time, and thank God for the strength that He has given me to go through all of this. God bless you.
Thank you. And who am I speaking with?
Pardon me?
And who is this?
This is Sister Doreen, Sister Marlene.
Oh, okay. I'm trying to pick up your voice. I haven't heard your voice for Okay.
I know.
Awesome. Thanks for sharing.
Yeah.
There's a question that was asked here if other churches were invited. Every time there's something that we have in this magnitude, there are a few churches that I would send the promotion to. But I'm gonna ask everyone from COP if you have contact with any church, whether it's Church of God or not, and we're having events like these, you can invite them. Okay, the more people that invite them, the more people will be aware and will be able to join. Go ahead, Laverne. Hello?
Sister Marlene, it's Karen. Yes, and to Sister Doreen, yes, other churches have been invited. For example, the lady that spoke before you, Sister Marcia, she's from, I think, Brampton Evangelistic Ministry. So, yes, this has circulated far and wide as far as we can get it. So it's just a matter of, you know, other people having the availability or the interest to join, but we do circulate whatever we're doing so that everyone can benefit from it.
It wasn't a question from Sister Doreen. Someone messaged me. Someone else's message was asking.
Sorry about that, Sister Doreen.
Okay.
And you know, Mr. Marlene, good night.
Good night, Sister Perry.
I am working in a nursing home, and sometimes I look at some of the residents and I said, you know, your nails are so better than mine. Look at your nails. They get pedicure, they get manicure, they get everything. And Praise Cathedral used to come here to have service. I haven't seen them for a little while, but they used to come every Sunday. They used to come to this nursing home where I work to have service. So I see other churches coming in, you know, because of the COVID, we haven't seen them come back yet, but they usually be here, Praise Cathedral. And I'm telling you, the residents, a lot of them down here, I'm telling you, they're up to marks. And even at the part-time job that I work, you have a resident council meeting, like just a resident, and you have the resident who is in charge. So they know their rights, and you cannot fool them. They know their rights, and they will tell you, you know, because some of them just come in there because they don't want to stay home by themselves. So a lot of residents is not because they fall off the wagon. They are okay, but they're there until, you know, they start to get much older. You know, so residents is some nursing homes are well taken care of. Some residents, some PSW don't do their job, but a lot of them, I'm telling you, really take care of the residents. I watch and I see I'm on the floor. Okay, so I just want to say thanks to the ladies, and everything that they said is well put together, and that's exactly what happened in the nursing home.
Thank you, Sister Perry. All right. So we are just a bit over the 9 o'clock mark, and this be go until 9. And we've used our time very, very wisely, and I believe that this was a good night where a lot of information was passed on, and we'll put it into practice and talk about it. I know I could not discuss with my mom about any of these decision-making thing because she would challenge us of us wanting to get rid of her. Even if we ask where she wants to be buried, whether it's Canada or Jamaica, she would challenge us that we want to get rid of her. It's just a thing that certain topics are taboo, and we just have to move beyond that and be real. Yes, that's right. That Sister Lorna is saying that it's important to let our family members or friends know our decision not to do DNR, and if that's what we want to choose. Yes, let our loved one know if we don't want to be resuscitated, if we stop breathing and our heart stop beating, or do everything in their power to bring us back. That's something that we need to discuss.
Sister Marilyn, and to Sister Lorna, and to anyone who struggles with the DNR status, I'm going to tell you what the research shows and what the reality is. So, if the person falls on the floor in front of a train, not somebody who's seen this on TV and on YouTube. You're talking about a trained, a certified BCLS person. So person who has gone through the training to conduct CPR effectively. If you fall in front of that person and right by that person's ankle happens to be an AED, that's the machine that we use to shock you back to life. If that happens, you have a 2% chance of surviving. That's the reality. It's a harsh and a cold reality. You have a 2% chance of survival and returning to what your base level was. What's your base level? You were up and walking with your arms swinging and you were driving your car and you were cooking your meals. As you age, that percent drops even more. So it was already sitting at 2%. So I can tell you, I may be 250 pounds and you are 80 pounds wet. Just remember, my job is to save you. I am not concerned that every rib that God has blessed you with, I will break it, because that's what I have to do to ensure that I get your heart pumping. And that is if the Lord permits your heart to go back to pumping. So please put those things into place. Am I discouraging you from being resuscitated? Absolutely not. It is a personal choice. All I'm trying to do is to bring the truth to you. The chance of you surviving is next to nothing. This was my reality 2 weeks ago, Tuesday. I just spoke with the resident. We were joking. She was laughing. 15 minutes later, she passed out in front of the caregivers that were caring for her. So remember, in that instant, we started CPR. We continued for 30 minutes. So the fire crew came on there, the first airway personnel, the paramedics came on board. But 30 minutes later, we still were completely unsuccessful. But did she die with most of her ribs broken? Absolutely. Because we tried our hardest. I'm saying she wasn't my patient, but I happened to see her 15 minutes prior to her passing out, laughing and talking. We were joking. So please put that in mind. When we do CPR, it is not a miracle. It is a medical procedure we're trying to do to sustain life, but it is extremely, extremely difficult to restart a heart that has stopped beating. This is not Grey's Anatomy. Believe me, it is not Grey's Anatomy. So be mindful as we ask for those things. Now, I'm saying the person's 35 years old, they're up and about, they eat well, they exercise. The chance of them making it, 9 out of 10, 9 out of 10. The person's 70 years old. They've got 10 medical conditions. They're wheelchair bound. I've got to pull them out of that wheelchair. I've got to yank them off that bed and put them on that floor in order to do an effective CPR. You cannot do CPR on a bed. You've got to put the person on the floor. I am not going to be the gentlest because I'm trying to get to that heart. So please think about DNR status. Please think about burial. Please think about what you want. Don't leave your end of life decisions for others to make. While you can make decisions and you're capable, please let your requests be made known to your loved ones. And I know we have some family members that absolutely will just shut the screen down. I am not talking about it. You're trying to kill me. You're trying to take all I have, but let our children or our decision makers that we're putting in place to make decisions when we cannot make those decisions, please let them know. But look at all the angles as we make decisions. Do not make poor decisions or put people that don't know you or know what you want to take care of you, because they will take care of you like they take care of themselves. Thank you.
Thanks for that reality check there, Sister Karen. Awesome. We could go on and on and on. And because this is reality, this about us, this about someone that we love. There's our neighbor or next of kin, we're giving care. It is real. It is real. All right.
Good night. Good night. I won't be long. I agree 100% of what Sister Karen said, but it's just normal. Many children would like resuscitation. Okay, because my dad, we were at the hospital, all of us, and at that time he was 85, I think, and they called cold brew, whatever it is. And we were there, and before they asked if we want to give resuscitation, and we say yes. One of my sister was almost arguing with the doctor, say yes, and she even tell the doctor, if it's your dad, wouldn't you like to give us, And I mean, other than that, they did give him resuscitation, and he lived to be 103, and he was 85 at the time. So, God. It's all about the family, what they want, and with God in the midst. So I don't know what to say, but I agree still with what she says. It's not everybody, but God knows. God got our back. God bless you.
The thing is, we respect the wishes and we grant the wish. However, it's the reality of it that there's that low percentage of and I'm even looking at, and I'm in 30 odd years of nursing, and I'm trying to think back of how many successful CPR I've participated in, and I can't even recall if there's 2 that has been successful. You go through, sometimes it goes even an hour. And sometimes depends, especially if it's a young person, the doctor will just be, okay, give this, give that. And of course, it's the medication that's making the heart go on, or when you're doing good compression and you see on the monitor that the heart rate is 40 or whatever, and then you stop to do a pulse check and all that, and you see flat line again, and it starts compression. So if you say, I want CPR, it's going to be granted. And based on what you just say there, the last speaker, be mindful, because I just encountered an abusive situation where I was even sworn that I'm there to call security just a couple of days ago. Just be mindful that we are people and we are giving care and we are trained in what we do. And sometimes what we're saying, you might not get what we're saying. And just be mindful of the words that we use in how we respond, and be very kind because it's a discussion. Never challenge if it's your family member, wouldn't you want that? No. Do you want CPR? Yes or no, and we just move it on. So just also be mindful of that, because as I said, I was sworn at and all that, and I had to quickly, as soon as I finished what I was doing in a safe way, I left the room because there was 4 family members in the room at me, and I left the room, didn't finish the care, and I went to the charge and I said, I will not go back in the room until they're out. But the charge nurse was already in the hallway being aware and what was going on, and security was already called, and they were escorted out, and I was able to finish the care I was giving, because it's a 0 tolerance for abuse. So, and I'm not saying, Sister Carol, that this was the case. I'm just saying, based on certain words, that we have to be really mindful and say things in a caring way and respond in a professional and a kind way, because this question that we're asking is not any to say right or wrong. Or
You know what?
Yeah.
It was my sister, you know, the doctor, how he was like pushing us not to. The way how he was going on, and he was saying, "Oh, he already lived his life." I was there when the doctor was talking like that. You know, he wasn't really, he didn't have a heart. No, I was a witness, so I'm not really
yes.
lying. Yeah. So
Yeah,
when my
if the
sister,
prognosis is not good, they're gonna tell you that based on age and health,
yeah, it's
his
the
health,
age they were basing on. But my
yes,
sister is a nurse also, right? So she was there, and that's why she answered him like
okay,
that. Is that yeah?
okay,
Because you know he was singing, and oh, he already lived his life. You know what I'm saying? And this was the first closest experience we had, so we were
okay,
kind of, you know, scared, and we love our dad. We didn't want him to go, but he lived how many years after that? 85 to 103 after that. So you know, God is good, and thank God. And I appreciate everything y'all said. Believe me, I learned a lot.
yeah,
And
you're
Sister Malik,
advocating.
I'll be calling you some other time. I'll be calling you later on too.
So you're advocating for you were the voice, and your sister was the voice for your voiceless
No,
father.
all of us agreed.
Yes. Okay, we
At
have
the time,
to. We
at the
have
time we
to.
were in the hospital.
Sorry. Go ahead, sister.
No, I said all of us agreed at the hospital at the time. Yeah, you know, but when she started to kick out is when he said, "Oh, he already lived his life." That's when, you know.
Okay.
Yeah.
Yeah. That
Yeah.
triggers.
He shouldn't have said that, you know.
Yes.
Okay.
Yeah.
Thank you very much.
So that's the thing there, and I'm glad you pointed that out, Sister Karen, because we are taught to keep our own biases to ourselves when we are giving care. So saying to the family he's already lived his life and all that, it's kind of
Yeah.
on that. I think a better term would say, like, based on his age and his health status, the likelihood of him surviving having CPR is not good. But then it's
But
still
it's what? Yeah.
yes,
It's
how
what
it
he
was
said.
said.
No?
Yes.
Thank you.
All right, Sister Hall, it's back to you. This is a hot topic and nobody wants to go to bed tonight. But Sister Hall, I'm handing it back to you. God bless. Thank you, everyone.
Thank you, Sister Marilyn, and thank everyone for coming out tonight. And I trust that everyone listened and there was something for you to take away, something to ponder, and the idea of long-term care. And I think based on what I'm hearing tonight, there is the long-term care, the nursing home, and there is the I think it's assistant living. I think maybe it was Laverne was saying, either Laverne or Karen was saying that people who do not want to live alone can move into some of these residences. So like she was saying, it's really not the end of the world. So, you know, that is something to think about also in this country. And again, it's important that we talk to our loved ones and share these information. And in our culture, you want to get rid of me, you're calling down debt on me, but then these are realities that are facing us every day. So I trust that everyone will take something. And of course, you know, we had asked to invite as much, put the word out there. So I want to say thanks to each and everyone for coming out tonight. Thank God. I'm